Let's get started. Today I want to discuss alcoholism or recovery from alcoholism and benzodiazepines. There is a relationship there and you all know about it, but there's one particular relationship nobody ever talks about, and I think it can play a significant role in recovery from alcoholism in certain situations. Let me break this down first of the things I'm not going to talk about. So we're talking about treatment for alcoholism from the beginning. One, it's the withdrawal stage. And everybody knows that in that situations, there's a substitution of benzodiazepine in different ways, usually long-acting. Many people like temazepam, some people like Ativan, in different ways to get through that acute withdrawal stage. Everybody knows that. There's nuances and important discussions in that area, but we're not going to touch that. Other than that, we also know that for alcoholism, there's multiple FDA-approved medications that supplement and have been shown to be very powerful in the treatment and recovery phase of alcoholism. We're not going to talk about that. We also know that there's a significant role by 12-step recovery programs that are infused in the treatment of alcoholism. We're not going to discuss that. There's also a psychiatric, psychological, behavioral engagement people can participate in, therapy, why you were an alcoholic. All of those issues involved around any addiction, we're going to leave that to the side. But there's one issue that is rarely talked about, and that is the role benzodiazepines play after acute phase of treating an alcoholic with benzodiazepines to help with the acute withdrawal stage. So you quit, oftentimes benzos are involved to mitigate severe withdrawal symptoms, and eventually they're tapered off. After that, there are many choices, and we can discuss all of those. But what role do benzodiazepines play in that more medium to long-term, maybe even indefinite recovery phase? What role do benzodiazepines play? And it's just never brought up. And I'm going to discuss that now. So let's take someone who does have an issue with alcoholism, and it's not really mainstay, and it's not really the standard of care. And in fact, I don't believe it's in any of the recommendations that that person should stay on a benzodiazepine. I believe, and I know from extensive experience, that this phase, this time period is significant in its relapse rate, right? No, you know, that acute phase, you can really dope somebody up or use different kinds of benzodiazepines. But the question that needs to be asked, and it should be in the algorithm of treatment of alcoholism with medication management. Remember, we're leaving all of the other parts of treatment out because I just simply want to, in a short period of time, address this issue. The benzodiazepine role in sustaining recovery for alcoholism. This is critical because once the patient is off of the alcohol, the question becomes quite convoluted, and one has to dissect through how did the alcoholism begin? What is it that they were self-medicating with? And to what extent was there an anxiety spectrum disorder in place in all of its manifestations, whether it's panic, agoraphobia, all the time general anxiety? What role did that play for the patient to push him into the alcoholism? And what you're going to find is that in a significant number of patients, the sustained abstinence is extremely difficult at this point in their life without putting them on some sort of a low dose benzodiazepine, medium to long acting. That's a different discussion. I'm not discussing that. I'm simply discussing the need and role for benzodiazepines after the initial phase of detox from alcohol, or acute withdrawals, which is actually the correct term, from alcohol, and making sure a patient is safe. What role do benzodiazepines play? And I believe if this was incorporated into the algorithm and the clinical consideration by the physician or whoever the treating clinician is, benzodiazepines actually do play a significant role and should be heavily considered for having any kind of sustained recovery or maintenance of abstinence in a significant number of patients. Why do I say that? I see it all the time. And in fact, I will kind of close this out by one example where I had a young patient, I believe early 30s or late 20s, and there was severe alcoholism involved, and he went into detox, rehab, comes out. There was also a significant amount of cocaine involved, and at times he was using benzodiazepines as well. And a few weeks out from rehab, which is when he came to me, and I started to sort of tweak, refine, get rid of a lot of the medications that he was on. He didn't even know why he was on. But I noticed that he was white knuckling it, barely making it day to day. And during that time, there was an episode where he went on a few-hour cocaine run on a Friday night. Eventually, there was 1 to 2 occasions where the alcohol came into play. So, you know, he had spent 2 to 3 months in detox, intensive outpatient, was sent home. But even the day he came to see me, he just looked like he was white knuckling it. He was barely surviving. In digging into the patient's history, and this is just one patient, I just want to use him as an example to bring the issue to light. Digging into this patient's history, there was a significant amount of anxiety disorder in different forms going all the way back to his teens and actually further. And alcohol was actually self-medication, coping mechanism. And so I eventually decided to have a conversation with him and his mother, who, although he was 30 years old, 29 years old, whatever he was, she played an extensive role in his recovery, support, and they were a tight two people, her son and herself. So I brought her in as well to include her in this discussion, and I told them my suggestion is we go on a low-dose benzodiazepine and make a couple of other changes and come off all this other stuff you're on, gabapentin, Seroquel, trazodone. He was, I think, 4 or 5 medications. I told them my reasoning. They were all for it. And we went ahead and started, I believe, Valium, it might have been in his case, maybe Klonopin, but it was the same medication that he would abuse during the times that he was also abusing alcohol and cocaine. I wasn't nervous at all, and I knew the effect this was going to have controlled by me, followed by me, closely observed by me, and I would check in on him often. We are, I think, many months later, and he actually has the best quality of life he has ever had. We've made other changes, small changes, got him off all the other medications, but I believe the most significant component of his well-being and recovery was adding the benzodiazepine into the mix at a low dose, and this has kept him from relapse. In fact, he's never went back to cocaine or alcohol. I'm not arguing that this is the case for everybody. I'm not arguing and never have argued that everybody should be treated in the same way. What I'm arguing for is the fact that when somebody comes off of alcohol, all the treatment modalities we have, not one of them really considers within that treatment modality for staying off of alcohol, none of them considers the role a low-dose benzodiazepine could play at this point to keep them off of the alcohol. Well, to me, this is harm reduction and dishing out controlled medications to minimize the potential catastrophe and damage from long-term or even short-term alcohol misuse, use, and abuse. Every patient has to be looked at from top to bottom and 360 degrees. Don't forget to like and subscribe and consider our membership. We are just starting to put them out. Thank you very much. See you guys soon. Peace.